first part. So I think we can get going.
Perfect. Sure. Well, I'm Dr. Teresa Walls. I'm a Peds Emergency Medicine doc at the Children's Hospital of Philadelphia. So on behalf of myself and Dr. Mark Auerbach, who just spoke from Yale, we'd like to welcome you to our webinar. We're fortunate today to have Dr. Kristin Ray, who is an Associate Professor of Pediatrics and the Director for Health Systems Improvement at the University of Pittsburgh Medical Center, as well as Dr. Stefanie Ames. She's an Assistant Professor of Pediatrics in the Division of Critical Care at the University of Utah. And their talk today is, titled A Health Services Approach to Pediatric Readiness Research, Access and Outcomes. And so this webinar is sponsored by our subcommittee, which is a Pediatric Readiness Subcommittee. We're part of the section on emergency medicine of the AAP. So you can go to the next slide. And the goal for our subcommittee is to create a community of practice. So I just put the definition here for everyone. A community of practice is a group of people who share passion or interest and learn how to do it better as they collaborate and interact regularly. So that really speaks to the spirit of today's webinar and a webinar series where we try and learn from each other and hear about the great work that everybody is doing. So if you're not already involved in the community of practice and would like to be, or you just want more information, I put the website here, and that's available publicly through the EMSC Improvement Center, as well as emails for Mark and myself. So next slide. And then just putting in a plug, we'll put this up at the end as well, but as you may all know, we're doing a next iteration of the National Pediatric Readiness Project survey, which aims to survey all emergency departments in the US about pediatric readiness. And the QR code there is a link to the website with lots of information. So we certainly encourage you to, if you work in an ED or have contact with those in your local EDs, that you encourage them to participate in this survey, because a lot of the great work that you'll hear about today comes from surveys like this in the past. So I'll turn it over to Dr. Ames, who's going to start.
So I want to start off today just by thanking Mark and Teresa for this opportunity to discuss pediatric readiness and opportunities for research engagement. In this webinar, we will first begin by reviewing prior research in pediatric readiness, specifically focusing on the relationship between pediatric readiness and mortality in pediatric critically ill patients. We will then review the variations in access to pediatric ready emergency departments in the US. In addition to these key studies, we'll be discussing some upcoming work and discussing pediatric readiness data and methods of utilizing this data, as well as other tips for pediatric health services research. The overall objectives for the webinar are listed here in this slide, but we will plan to save questions for the end of the webinar, but feel free to go ahead and put them in the chat as they come up. So I'm going to kick us off today with my presentation entitled Pediatric Readiness, Preparing for the Critically Ill Child. I have no financial disclosures to report. So for this portion, my portion of the webinar, I'm going to begin by discussing my why of how I got involved in pediatric readiness research, and then we'll be reviewing the work I have done focusing on critical illness and emergency department pediatric readiness. Next, I'll briefly go over a few ongoing projects I'm engaged in and with some collaborators, and then we'll finish with a few tips for pediatric readiness research before handing it over to Dr. Ray. So the first question is, why is an intensivist focused on pediatric readiness of emergency departments? Well, although my clinical time is spent only in the ICU, I am a health services researcher, and my goal is to improve delivery and organization of healthcare for children with critical illness, both in the ICU as well as outside the ICU, including pre-hospital care. This interest really began to develop during my fellowship training under the mentorship of Dr. Jeremy Kahn, who is a health services researcher and adult intensivist who also mentored Dr. Ray and myself. My initial experiences first developed, as most research questions do, with some anecdotal experiences of patients who were referred to our ICU from outside hospital emergency departments. As an ICU fellow, we were responsible for taking all transport calls for the hospital and would interact with as many as 10 to 15 emergency departments on a busy night, referring patients to our hospital. There were several clinical scenarios that came up where I would ask the ED physician for more information or to enact a treatment plan, and they were not able to do it, not because of competency or skills, but because of systems limitations or lack of supplies. And this to me was a huge inequity and would often put critically ill children at risk for continued decompensation, ultimately leading to patients arriving at our ICU in worse condition. After these experiences continued to occur throughout my fellowship, I began to look at literature for inequities in emergency care for pediatric patients, and this other research I found really fueled my interest in this topic. For example, this study, which is 20 years old at this point, but when I was looking at the data, this is what I was finding. This study from 2000 demonstrated that at that time, majority of pediatric patients were treated at adult trauma centers, and utilizing the Pennsylvania Trauma Registry, they assessed the impact of pediatric trauma centers on mortality of injured children. And they found a significantly lower mortality rate at pediatric trauma centers. In addition, in looking at quality of care, this study published in JAMA Peds in 2016 evaluated differences in quality of resuscitation in different ERs. This prospective multi-center cohort study evaluated interprofessional teams in the care of their care of 3 simulated critically ill patients. Their results demonstrated pediatric ED teams often outperform general EDs in most domains. The inequality of emergency care for children was also highlighted in this 2006 Institute of Medicine report. This report and the research I discussed, as well as many other publications at the time, provided fuel to improve the care for children in the emergency department. In 2009, national guidelines for the care of children in the emergency department were updated. And following this, a national public health initiative was developed to assess the pediatric readiness of all emergency departments in the US. This is known as the National Pediatric Readiness Project. This work resulted in a 55-question web-based assessment of emergency departments to assess critical components of their infrastructure, administration, care coordination, policies, and equipment. And this survey was sent to all emergency departments in 2013, and about 83% of them responded, providing an abundance of data, which is the data that we are going to be talking a lot about today. The results of this survey were published in JAMA Peds in 2015, and overall, the median weighted pediatric readiness score of the whole cohort was 68.9. with the median varying by volume seen here in this slide. To me, this really ignited my passion for this, showing that a lot of hospitals in the US are missing one or more key factors to providing care for children with emergencies, and really triggered that thoughts that I had anecdotally that hospitals may not have all the resources they need. And this showed that that seemed to be true based on this data. So with this background of recognizing there may be differences in treatment quality, as well as demonstrated variation in pediatric emergency departments as defined by the Pediatric Readiness Project, I wanted to ask the question, does presentation to an emergency department with higher pediatric readiness improve outcomes for children who present with critical illness? With this question in mind, we developed the research study, which was published in 2019 in Pediatrics, entitled Emergency Department Pediatric Readiness and Mortality in Critically Ill Children. The objectives of the study were first to understand where critically ill children were presenting for their initial care. We wanted to know if most are coming to well-prepared hospitals, or are they often presenting to underprepared hospitals? And then to evaluate the association between emergency department pediatric readiness and mortality during hospitalization for critically ill children. To achieve these objectives, we conducted a retrospective cohort study of pediatric patients from ages 0 to 18 years old who presented to emergency department with a critical illness, which we defined in this study as having admission to an ICU or death during their encounter. We utilized the 2013 Healthcare Cost and Utilization Project datasets from New York, Nebraska, Iowa, Florida, and Massachusetts. These datasets we used were the State Emergency Department database, as well as the State Inpatient Database, or the SID. We use these states and these databases specifically because we could follow patients across time. So the SED is an administrative data set that contains encounters from emergency departments where the patient was either discharged or transferred to another hospital, while the SID contains administrative records from encounters with an inpatient admission, which so therefore includes some information if the patient was then admitted to the same hospital. So combining these two data sets through unique patient identifiers, which were only available in certain states, including these 5 listed above, we were able to track a patient who presented to hospital A and then was transferred to hospital B and admitted there. And so we could follow them across time to link their outcome to their initial emergency department care. We also, this study involved a linkage of multiple data sets, and including the SID and the SED, which I just described. We also linked our data to the 2013 National Pediatric Readiness Project scoring for each hospital. And this was done through hospital level identifiers. We also looked at a couple other data sets to evaluate hospital characteristics, again, linking on hospital identifiers, not patient level identifiers. So this allowed us to build a data set that included information about patients, as well as the hospital characteristics and their pediatric readiness score, and follow patients across time to different hospitals and see their outcome, their in-hospital outcome. The primary exposure of this study was the weighted pediatric readiness score at the initial emergency department of care. The primary outcome was mortality during the episode at all. And we began by categorizing and comparing hospitals and hospital characteristics by the quartiles of pediatric readiness, so at the hospital level. We then used a logistic regression to evaluate the relationship of pediatric readiness and mortality, adjusting for age, severity of illness using the PCARN severity of illness coding, and chronic conditions using a commonly utilized method. These variables were a priori determined because we thought that these might have the most impact on mortality. In addition to using a logistic regression to evaluate the difference in quartiles, the relationship between the quartiles, we also use fractional polynomials to assess the relationship of pediatric readiness score as a continuous variable. Fractional polynomials allow for the assessment without assuming a specific shape, like a linear shape of the relationship between the exposure and outcome. So overall, in these 5 states, we identified a little over 20,000 critically ill children who presented to 426 hospitals in 2013. Again, 2013 was chosen as our data because that's the year the 2013, the National Pediatric Readiness Project survey was done. The median pediatric readiness score of these hospitals was 74.8, which was a little bit higher than the national score. Hospitals with lower scores were often smaller hospitals without dedicated pediatric services, such as an ED ward or ICU. And the typical child who presented to hospitals with lower readiness was older and more likely to not have chronic conditions compared to the patients who presented to hospitals with higher readiness. So to answer our first question, where are these patients presenting? Where are critically ill patients presenting? Overall, we found the majority of children, so 69%, presented to hospitals in the highest quartile of readiness, while a minority presented to the lowest quartiles of readiness. However, when evaluating unadjusted mortality by quartile of pediatric readiness, there's a clear trend, unadjusted, that the lower the pediatric readiness scores are associated with higher mortality in these patients. And that as the readiness increases, the unadjusted mortality decreases. So the primary results of our study are shown here, which addresses this unadjusted mortality, adjusting for age, severity of illness, and chronic conditions, as I mentioned before. In the primary results of our study, we found that utilizing this risk adjustment model, the odds of death in the lowest quartile were 4-fold higher than the highest quartile when adjusting for those factors, those confounding factors. The relationship between, we also assessed, as I mentioned earlier, the relationship between pediatric readiness and model as a continuous variable and the adjusted predicted mortality using fractional polynomials. Again, fractional polynomials are a family of different curves with a standardized process for testing and identifying the curve that fits this adjusted association the best. As you can see, there's after 50, a weighted pediatric readiness score of 50, the relationship seems to, as readiness increases, mortality decreases. However, this doesn't hold true for the lower ranges. Unfortunately, as you can see, there's a significantly wide confidence interval here, making this data very hard to interpret given the low volume of patients, as I mentioned earlier, that we're seeing at these less ready hospitals. So it makes it really challenging to draw any conclusions and think further study is needed for that. We repeated the analysis, both the logistic regression and fractional polynomials in subgroups of patients, including traumatic brain injury, cardiac arrest, and sepsis, and saw similar results, which I'm not going to discuss today just in the interest of time. Our study was limited by the use of administrative data, which limits the use of clinical variables, and so there may be unmeasured confounding. However, as I mentioned earlier, the average child who presented to a hospital which was less ready based on the National Pediatric Readiness Project was older and less complex, and so therefore the confounding may actually be in their favor, and this relationship may in fact be stronger than we reported. In addition, there could be other outcomes that we did not consider based again on the use of administrative data, such as neurologically favorable survival, and that's something we have not been able to assess with this data set. Another limitation is our definition of critical illness, recognizing that some patients who are admitted to ICU may not have their high risk of mortality as others, and that some patients who die in the hospital may not have presented as critically ill. However, when we look at this distribution of ED severity based on the PCARN severity of illness scores on admission or in the emergency department, they were consistent across all groups. So we expect that this definition is applied equally across all quartiles, and so their relationship should hold up. And so overall, we concluded that for pediatric based on the results of our retrospective cohort analysis, that presentation to a hospital with high pediatric readiness is associated with a lower mortality for patients with critical illness compared to presentation with a hospital with low readiness. These results support the efforts to increase ED readiness for pediatric emergencies. In addition to this work, I have since been engaged in 2 national working groups to continue research on pediatric readiness and improve care for critically ill children. I'm going to talk a little bit about the work that's ongoing in these groups. So the first is the Pediatric Readiness Study Investigators. This is a group led by Dr. Craig Newgard out of OHSU, and based on his funding from the NICHD and HRSA. Dr. Newgard is currently leading a team of multiple investigators with different writing groups focused on the evaluation of pediatric readiness and pediatric trauma outcomes. Dr. Newgard's work is utilizing novel cohorts of children and utilizing probabilistic linkage to link different data sets together to be able to ask different questions. An example of this work has recently been published in JAMA Peds as of yesterday. And I'm just going to highlight this study today, but I really encourage you to go check out this recent research. So this study is entitled Evaluation of Emergency Department Pediatric Readiness and Outcomes Among U.S. Trauma Centers. And similar to our work where we evaluated the relationship of pediatric readiness and initial ER presentation and critical illness, this study evaluates the association between pediatric readiness and patient outcomes in trauma patients using the National Trauma Database and linking it to the NPRP data. The primary exposure of this study is the weighted pediatric readiness, similar to our prior study. And the primary outcome is either in-hospital mortality or any of one of 13 serious in-hospital complications, which are collected by the National Trauma Database. These complications include things like ARDS, DVTs, surgical complications, or unplanned ICU admission. Overall, this study identified approximately 370,000 pediatric patients, trauma patients in 832 trauma centers over multiple years. Almost half these patients presented to the quartiles presented to hospitals in the 4th quartile, similar to our study, and approximately 11% of patients were admitted to hospitals in quartile 1. The presentation to quartile by trauma level is shown here. You can see the distribution between adult trauma centers in the 4th quartile versus pediatric trauma centers in the 4th quartile versus the 1st quartile. After adjusting for patient demographics, comorbidities, and multiple markers of initial severity of illness, this study found that the odds of death were lower for patients who presented to the highest ready quartile when compared to patients who presented to the lowest quartile of readiness. And this relationship is shown in the top over here. This relationship was not maintained when combining with in-hospital mortality with in-hospital complication, which may be because they're not related to emergency care, but rather to inpatient care. Interestingly, I think the team also calculated the mean number of additional lives saved per year if 100% of the children in the lower quartile, the lower readiness quartile EDs would have been treated in the highest ready quartile. And this scenario they found would have resulted in 126 saved lives per year. So this study concluded that injured children admitted through high readiness trauma EDs had lower mortality compared to similar children cared for in low readiness EDs. There was preventable mortality from care in lower ready EDs. And I didn't show this data, but I encourage you to look at the paper that was published. They also use fractional polynomials to look at the relationship between the weighted pediatric readiness score and trauma and outcome. And they found that there's a consistent decrease in mortality at a pediatric readiness score of 93 to 100, which could provide a benchmark for US trauma centers moving forward. And that's just one example of some work that the Pediatric Readiness Study Group is undertaking. Using these data sets from Dr. Newgard's research, there will be multiple upcoming projects to look out for, and these are some examples. And Dr. Newgard's initial focus is on trauma, but future work in the group will also include evaluation of other cohorts. So in addition to the assessment of pediatric readiness of emergency departments, I'm also part of the National Task Force on Community Hospital Readiness for the Acutely Decompensating Child. This work seeks to evaluate the readiness of community hospitals to assess and care for acutely decompensating children while they await transfer to a center with a pediatric ICU. This work is necessary as studies have shown in the past that a large majority of pediatric hospitalizations actually occur outside of tertiary care centers with ICUs. And children can be cared for in a large variety of settings with a variety of resources or lack thereof. And a center's readiness, just as in the ED, to recognize and care for acutely deteriorating child is crucial to improving these patient outcomes. However, prior qualitative work has shown that there can be many barriers to this process. These barriers may include staffing models, subspecialty access, equipment, systematic gaps, and inter-hospital delays. These barriers represent opportunities to improve and also demonstrate that many community physicians may be undersupported to care for the children that they have in their hospital. And although many different hospitals have many different resources, they all have a similar need when it comes to an acutely deteriorating child, because the management should be similar. Therefore, there's a call for a national standard in care for community hospitals similar to that of the Pediatric Readiness, and a development of a checklist is necessary based on these factors. Therefore, the Impacts Inpatient Work Group, the National Task Force on Community Hospital Readiness for the Acutely Decompensating Child, has been developed, led by Dana Quinnaby from Nationwide Children's Hospital. This task force includes a work group of nurses, RTs, physicians, and pharmacists from both community as well as academic hospitals from a variety of different levels of training, as well as levels of different types of training. The goal of this work group is to develop a comprehensive checklist for community hospital to use, similar to the ED Pediatric Readiness, to assess its readiness to recognize and initially stabilize an acutely deteriorating child admitted to the inpatient service. And we hope that community hospitals can then use this checklist to perform a gap assessment and to support the needs of the physicians in this workforce to be able to adequately care for these children while they await transfer to an ICU. So those are some examples of ongoing research and things to look out for in the future. Lastly, I was asked to give some tips and tricks on getting involved in pediatric readiness. I think the most important thing is to identify a research question that is applicable to pediatric readiness. And the first thing to do is to just look around your workforce and identify where are the inequities in your care, and where do you identify gaps in care? Where does the care not seem to be the same across different patient populations, across different types of hospitals? The second thing I want to mention is mentorship. It's really helpful to have someone who is knowledgeable about the process and data to help you as you go. And that could be local or across universities. One big takeaway from this session is the NEDARC website that's listed here. The pediatric readiness data that has been referenced in both studies that I talked about, the NPRP data, which has the readiness score for each hospital that responded to the survey, is available on this website through a process where you submit your research question. I'm not sure if this is well seen, but you can submit your research question for review, and then they help you develop a research question, fill out a research form, and will provide the data. It does not require funding to do that. And so I encourage you to look at that website. The 2021 survey is being repeated now. And so that data should be available in about 6 months. So waiting for that new data would be really valuable to assessing how things have changed and how the mark has been moved. Another key point I hope you were able to get from the studies I have described is to consider different data sources. Both studies I described involved linkage of different data sets to gain the right information. And so for my original project, I did this through merging data on unique patient and hospital identifiers. And for projects under Dr. Newgard, probabilistic linkage is being utilized. It's also important to understand your data sets and data elements and to consider what can be done. Also, you need to be creative and innovative with administrative data. It's often that you want to ask a question that needs certain variables, but the data sets don't have them. So can you merge with another data set, or can you find a different way to represent the construct that you're trying to identify? And finally, networking and collaborating as much as possible. There's a lot of exciting work going on, and I hope that this talk sort of shows you some of the work that's ongoing, and there's a lot more work to do to ensure that all children receive the appropriate care that they need. I'm sorry, this is the website I was referring to. And so finally, I want to thank my mentors, particularly Dr. Khan and Dr. Lenora Olson, for their amazing guidance and mentorship in this work. And I want to thank all of the collaborators who've made this possible and are continuing to advance this field. Thank you.
Wonderful. Thanks so much. So I'm going to pick up the baton now and speak for a little bit. I'm Kristin Ray at the University of Pittsburgh. And it is a pleasure to follow on the presentation of Dr. Ames, and also want to echo my gratitude to Mark and Teresa for inviting us here today. So I'm going to speak today about a project that I did with the team listed here using the NPRP data that was published in the Journal of Pediatrics a couple of years ago. But similar to Stefanie's presentation, I'll start with a little bit about myself and how I became interested in this question, and then transition to talking about this particular project. And then again, some future directions that I'm doing with my work and some tips for collaborating and using these data. So in terms of the place to start with my background and my why is that while I live in Pittsburgh now, which is represented with the star here, I had a childhood where I moved through many different places with the purple, and then in my early adult years, living and working as a pediatrician in the blue spots and having extended clinical time in these green spot places. And so altogether, that gave me a deep sense as a child heading into med school and then later as a clinician of the ways in which place shapes opportunity and resources available to children and families. And as I moved more into the clinical context, recognizing how that in turn shaped health. And so that gave me great interest in understanding how the availability of different, the context of care and the options that were available to children shape where they receive care and the quality of care that they receive. I am now trained as a general pediatrician, a health services researcher, and a clinical informatician. And the majority of my work focuses in one way or another in looking at how we can improve pediatric health system access, outcomes, and equity. And one of the things in particular, coming to Pittsburgh, I had previously been working in rural New Mexico, and that was a place where I was practicing where the trade-offs between what care is closest to us versus where is the most pediatric specific care was an issue we faced every day with thinking about outpatient referrals, emergency rooms, and transfers for our patients. And so that question, understanding how proximity to care, is only the distance to care is only one dimension of understanding access, and how we can layer on not only proximity or travel time, but also thinking about what's the quality of care for you when you get there, specifically for children. And so these questions, I often come back to my favorite conceptual model, which is this patient-centered access to care model published in 2013 by Levesque and colleagues. And what I like about this model, it integrates much of what is published in a range of other access to care models, but it highlights the patient care experience down the middle, where you have patients moving from having a healthcare need, perceiving that need, and deciding to seek care, reaching care, and then actually accessing care, and then experiencing the consequences of that care. And so I think, number one, highlighting the patient experience there. But the other thing this model does is it separates out the factors that are on the system side on the top, where we think about where are we located, how do people reach us, what are the costs, and what's the quality once they get there. And then the factors on the patient side on the lower half, where things like their living environment, social support, mobility influence how readily they can interact with the healthcare system, depending on how the healthcare system has set itself up to be accessed. So this particular tension with thinking about geographic location and then the technical and interpersonal quality was an issue that I had lived and breathed in rural New Mexico and wanted to try to understand better, and really framed me coming to this data set. So as Dr. Ames mentioned, in 2013, the NPRP data assessment was fielded again, and then this was the one of the many, but a super important publication that came out of that work, describing the National Assessment of Pediatric Readiness of Emergency Departments, including the general sense of where the numbers were with how ready emergency rooms across the US were as of that survey. So that provided us with some really important understanding of hospital level findings. What at the hospital level is the median weighted PEDS readiness score? How does at the hospital level, the weighted PEDS readiness score, how is it associated with hospital level variables? What we wanted to do is take that one step, build on that with an additional step by asking Where are these hospitals located relative to the pediatric population? And maybe from the patient perspective, when emergencies occur, will parents and families be able to travel quickly to an emergency room with high pediatric readiness? And so to do that, we turned to a geospatial analysis using these same data. So to frame the question more specifically, our analysis that I'm going to describe, we sought to determine the geographic accessibility of emergency rooms with high pediatric readiness for US children by assessing the percentage of children living within a 30-minute drive time of an emergency room with high pediatric readiness. So what this means is, whereas before the unit of analysis was the emergency rooms and counting up what things looked like at the emergency room level, here we needed to understand where these emergency rooms existed in space, and then where the pediatric population was as well. So this meant we first located the emergency rooms. And so to schematically represent this, here the emergency rooms are the triangles in gray, and you can imagine that the blue is a geographic area and the little dots are children living in that geographic area. Then some of those emergency rooms have high pediatric readiness, and so we can identify those, and those are now hypothetically labeled as stars here. And then among those emergency rooms, for all sets of emergency rooms, we can draw 30-minute drive time radii around the identified emergency rooms and count up the proportion of children falling within each of those circles. And so that's the general idea of what we were seeking to do. And why this matters is, in this map here, 50% of emergency rooms have high pediatric readiness. But you can see there are children who have access to those emergency rooms, children who have access within 30 minutes to a different emergency room, and then a subset of children living outside of either of those circles who would represent children who can't get to any emergency room within 30 minutes. But those same, if you have 8, again, emergency rooms with half of them being pediatric ready, they could also be clustered like this, or they could be clustered geospatially like this. And so those provide really different, while it's still 50% of emergency rooms, when we're thinking about children and how children can access care, they could be very different stories. So with that background, what we did is we partnered with the amazing team who had collected the NPRP data and performed a cross-sectional geospatial analysis using those data. Now that included a large sample of 4,959 hospitals that were that were in the non-territorial US, and within those, there was the 82% response rate, which is amazing for a survey. However, in a geospatial analysis, we need to understand what's going on at the hospitals that didn't respond, as in addition to the ones that did respond. So we matched those non-respondents to the AHA database based on hospital name and state and other hospital information. And that allowed us to identify or fill in some at least AHA level data for an additional 790 emergency rooms. And then there were 79 that we couldn't match to that data set either. So that gave us our sample of emergency rooms. And from those, we then needed to assign a weighted PEDS readiness score to each of those hospitals. And as a reminder, a weighted PEDS readiness score of 100 was designed to mean that that emergency room met the essential guidelines for pediatric readiness. So for those who responded to the NPRP 2013 assessment, we assigned their hospital with the weighted PEDS readiness score from their survey responses. For the non-respondents who we were able to match, we went through a process of multiple imputation using the AHA level hospital data and using what we could learn from the association between the respondent hospitals and those variables to impute 10 plausible scenarios for each of these non-responding hospitals that we were able to match. And then those 79 hospitals who we weren't able to match were excluded from the analysis. We then took all of those emergency rooms now with their either known weighted PEDS readiness score or their set of 10 imputed weighted PEDS readiness scores, and dichotomized them at different levels to look at different thresholds for whether the emergency room met a specified level of readiness. And so in our first analysis, we looked at the hospitals that had a weighted PEDS readiness score of 100, which was the highest possible score, again, reflecting that the emergency met the essential guidelines for pediatric readiness. And then we used the 90th percentile and the 75th percentile scores to identify hospitals with high levels of pediatric readiness. And then we also looked at subscores based on the questions more related to equipment, more related to personnel, and more related to protocols and processes. So that allowed us to populate our map with the emergency rooms, identify those with higher and lower weighted PEDS readiness scores, and then we needed to populate the map with the pediatric population. And for that, we used US Census data. We identified from the census the number of children 14 years and younger living in each zip code. As a sensitivity analysis, we also performed this looking at the same analysis with the number of children living in each zip code who were 17 and younger. And so then we took our hospitals and built 30-minute travel times around each one, and identified for each of those zip codes if we, here's an assumption we had to make, but if the children in that zip code lived at the geometric centroid of that zip code, were they inside or outside of that 30-minute travel time radii? And so then we were able to assess what % of children across the US lived within 30 minutes of the hospitals meeting the varying thresholds. So this then is our main top level results, where we looked first at a national level. And so here we first looked at just if we made didn't use the PEDS readiness data and just looked at, can you get to an emergency room within 30 minutes of travel time? We found that 93.7% of kids in the US could get to an emergency room within 30-minute travel time. And there were 6.3% of kids in the US who could not within 30 minutes of drive time. We then looked at, if we use the maximum weighted PEDS readiness score, what % could get to an emergency room with a maximum weighted PEDS readiness score, so a score of 100 within 30 minutes. And we found that 33.7% of children could get to an emergency room that had a weighted PEDS readiness score of 100 within 30-minute drive time, which left an additional 60% of children who could get to an emergency room, but an emergency room with a lower level of PEDS readiness. And if you look across the rest of this row, it shows the % of children who could get to an emergency room with a weighted PEDS readiness score at or above the 90th percentile of scores and at or above the 75th percentile of scores. We then looked at this by census division to understand how this varied geographically across the US. And so in this first column, we have you can see that in the New England Census Division, 98.2% of children could travel to an emergency room within 30 minutes, compared to in the Mountain region, 79.9% of children could travel to an emergency room within 30 minutes, leaving 20% who could not. And then if we move over to looking at the ability to travel to an emergency room with the maximum weighted PEDS readiness score, the variation by census region ranged from 56.2% of children in the Mid-Atlantic region and all the way down to 14.9% of children in the East South Central region, with the remaining column showing next to this showing that 41% of kids in the Mid-Atlantic region could travel to an emergency room, just not one with maximum PEDS readiness. And that was true for almost 80% of children in the East South Central region. We can show these same data graphically. And look at the ability to travel to any emergency room. And so this is a chloropleth map looking at these census divisions. So there's just 9 color fields here. And you can see that all of the census divisions, except for the mountain region, were in the 80 to 100% being able to travel to an emergency room within 30 minutes versus the mountain region with their score of 79.9% of kids being able to travel were in the next category down. But then when we add in the additional thresholds, this is looking at the percentage of children who can travel within 30 minutes to an emergency room with a weighted PEDS readiness score of 100. And there you can see the variation ranging from the lower percentage of children in the East South Central region and the higher percentage of children in the Mid-Atlantic region. And so, as I mentioned, we looked across different thresholds. And so in addition to the any emergency room and the maximum weighted PEDS readiness score maps that we just discussed, we could visualize this at the 75th and the 90th percent level. And the final part of this analysis, looking at scores themselves, was we looked at subscores, so the items and the weighted PEDS readiness score related to the personnel. So that involves who is on staff and what is the training that they have, their equipment, and then their processes and protocols. And so here we could also see what percent of children could travel within 30 minutes to an emergency room with a maximum weighted PEDS readiness score in each of these domains. additional piece that we wanted to look at is to understand what choices families are making when they're deciding where to seek care. And this may be a choice that is kind of known and explicit, or it may be one that's happening kind of beneath the surface for families. But going back to thinking about what % of children are within 30-minute drive time of an emergency room with a specified score. These are the levels, the numbers of the % of children we found across the US that were within 30 minutes of a weighted PEDS readiness of 100, a 90th percentile, and a 75th percentile emergency room. And then we added on for these kids, what % of them had was this hospital that met this threshold the closest hospital to them versus did they have to drive farther to get to a hospital with this level of score compared to an alternative that was available to them. And so here it's the same graph, but now coloring in those two sections. The yellow are those that the emergency room with the specified score was the highest or was the closest emergency room for them versus those in gray had a closer emergency room with a lower pediatric readiness. So all in all, what this study showed us was that 93.7% of children of the pediatric population lives within a 30-minute drive time of at least one emergency room, but only 1 in 3 live within a 30-minute drive of an emergency room meeting all essential guidelines for pediatric readiness. And that most children who live within 30 minutes of an emergency room with high pediatric readiness have a closer alternative emergency room with lower pediatric readiness. There's some important limitations to bring up here. One is just in thinking about our construct of access, we focused on geographic access and we didn't look at issues of capacity, hours of operation, costs, or cultural competency at these different hospitals. And so those are some other factors within models of access to care that we didn't include in this analysis. And then also we focused on just on-road drive time, which does not reflect the experience for people who have limited access to vehicles or may rely on public transit. And so even within the domain of geographic access, there are other factors that may be at play for individuals. Additional limitations, there was the 18% non-response rate for included hospitals. And so for this analysis, it was important for us to understand what those hospitals most likely looked at, and we did multiple imputation for the non-responders. We also did a sensitivity analysis where we coded all non-responders as low PEDS readiness and all non-responders as high PEDS readiness to further understand the range, the degree to which the readiness of those hospitals might sway our results. Also, this analysis was limited to the non-territorial US. We had some questions during the review phase about the varying definitions of pediatric patients. And so we did sensitivity analysis focused on our main result looking at children 14 and younger, and an additional analysis looking at defining children as those 17 and younger. That had very little impact on our findings, in part because the distribution of those 15, 16, and 17-year-olds at across the US was relatively similar to the distribution of those 0 to 14. And then finally, this is all about looking at what options are available to families and doesn't look at how they actually make their choices or where visits occur. So the implications of these results, one thing that I think is important is that this shows us that the emergency rooms are structurally there, and that by improving readiness within the existing emergency rooms, we can improve access to PEDS readiness within a 30-minute drive time from 33.7 to 93.7 of US children. An alternative finding could have been that there was a larger percentage of kids who just didn't have any emergency rooms nearby them. And we still need to think about solutions for that population, but it clarified the degree to which improving care within existing emergency rooms can improve access for children. But I think it also elevated the question of the point that for most of the pediatric population, a choice must be made between seeking care at the closest emergency room versus the most pediatric ready emergency room, raising questions about how to support families in making informed choices. So in terms of some of the directions I have gone since this work, it's really focused on these questions of choice and understanding context of care. And so some of the work we've been doing recently has been looking at how neighborhood and primary care contexts influence family care seeking decisions. Some of this work we've done through survey analysis, and then we've also done some additional geospatial analysis looking at block groups within Pittsburgh to understand where emergency room visits are lower than we might expect based on kind of socioeconomic factors, and what we can learn from what we're calling the bright spots in those communities where kind of existing data would tell us emergency room visits might be higher based on concentrated disadvantage socioeconomically, and yet we're learning a lot from those communities. And then on the other side, oops, I went forward one too many. One of the current studies I'm working on is understanding, again, at the family decision-making level, how does telemedicine and the option of telemedicine alter the perceived trade-offs between ability to get to care and the quality of care, and how people balance these issues of convenience, access, costs, anticipated quality. And so that study is ongoing, where we're talking with parents and caregivers to understand their decision-making about where, when, and through what modality to seek care. This is focused on the other extreme of the types of cases that Stefanie is looking at, with high complexity and ending in emergency rooms and critical care units. We're looking at children with acute respiratory tract infections to understand care-seeking decision-making at that level. And I think the tips I have to offer related to using these data really echo a lot of what Stefanie mentioned already. And I think one is, in terms of investigating data availability, there are so many big, rich data sets out there, and none of them are perfect, but through triangulating and linking, you can get to answers to a lot of interesting questions. And I think especially for people in fellowship or early career, it's a great way to get into some questions that maybe complement some other work where you might be collecting your own data, but a great way to enhance your skills and to understand what exists through linking these different data. And so there are many data available online, but also asking around, looking at what other groups doing similar work have used can give a lot of power. And then thinking through the range of ways of linking, both the more deterministic, but also the probabilistic linking, can add a lot of power and exciting opportunities. I think collaborating early and often, I think one of the joys of working in research and quality improvement is being able to work with amazing, inquisitive individuals. And so reaching out and having conversations about, either to, explicitly collaborate on a project, but also to learn from each other in terms of data availability and processes can be really important. And then, back to that idea that no data set is perfect. If you know your data limitations, can anticipate the potential direction of biases, think about ways to bring in other data to assess that, or to address that can help overcome some of those initial data limitations. And then, just as Stefanie mentioned, the NEDARC website, this is the link there again to reach out if you're interested in thinking about PedsReady data, but again, probably would aim to use the 2021 data at this point, which should be ready, we're hoping, next year. So with that, I want to thank all of the people who helped make this work possible and who contributed and collaborated, especially Dr. Olson and Khan, as well as the rest of the team listed here. And to summarize both of our pieces together, some of the lessons I think that we've learned through this work to date. Number one is that presentation to hospitals with a high pediatric readiness score is associated with decreased mortality in critically ill pediatric patients. But that 1 in 3 children live within 30-minute drive time of an emergency room meeting all essential guidelines for pediatric readiness, and that most children live within 30 minutes. Most children who live within 30 minutes have an emergency room with high pediatric readiness have a closer alternative emergency room with lower readiness. So altogether, this is showing us that pediatric readiness matters, but that we're not at a point that is the default of what kids are going to receive. And so both improving our hospitals and helping children to land at the best place for them requires ongoing work. And so we both welcome questions and comments, and our emails and our Twitter handles are here. And I think that brings us to back to Teresa, if you wanted to revisit these points before we go to questions.
Sure, thank you both so much. It's really cool to hear about all the work that you guys have been doing. And so just wanted to throw up again the website for our community of practice, once again, which is through the Pediatric Readiness Subcommittee of the Section on Emergency Medicine, and then the National Pediatric Readiness Project, which is, as these guys mentioned, happening now in EDs all over the country. So I think, Mark, can I throw it back to you for questions? I know you've been active in the chat, and we have a couple, I think, a time for a few questions before we close out the hour. Or should I do the questions? I apologize. I didn't put me on the spot.
I think my audio is back working now. So there's been a
Okay.
lot of great questions. Thank you so much to our esteemed speakers. Really fantastic summary of some very important work. So I think that, you know, just sort of coming back to the beginning of the talk with some questions, I think there was a question about that overlaid sort of these two efforts. So were you able to differentiate or can we differentiate outcomes based on proximity to hospital or population density? So I think this sort of gets at some of the concepts of, you know, bringing together maybe these two types of projects. And I was just curious, you know, do we see a path to differentiating outcome based on proximity to hospital or population density, i.e., you know, rural versus urban settings?
I can take an initial answer, and then I don't know if Stefanie knows if there's any ongoing work in this space. I think we've thought about that, and I would love to see work in that space, but there's a complex issue with if someone is bypassing a local hospital to go to the local children's hospital, is there greater complexity in that kid and they're maybe more known to that hospital versus, you know, so the degree to which there's a choice being made, which is part of what we wanted to highlight, but the degree to which that might drive some selection biases that we need to account for is just one piece to address. So I think it's super important, and would love to support people in looking at that in still more detail. And Stefanie, I don't know if you know if the group is doing any work in that space.
I know that I'm not sure that specific question, but I think the pediatric readiness study group is looking at EMS data and trying to see, kind of identify that distance of time and how that impacts the outpatient outcomes for both short and long term. I do think it's, as Kristin mentioned, a very complex issue, because we thought about this a lot when we were developing our question is, so if the answer is that you need to get to a pediatric emergency department, are we asking them to drive longer and avoid stopping at other hospitals? Would that change the outcome then? So if they drove an hour to get to the hospital rather than stopping at the closest hospital, would that mortality then still, you know, their chance of mortality in a patient, particularly in a critically ill patient where time matters a lot? It doesn't seem like that might not be the answer, but if EMS is involved and sort of looking at that EMS data might be a solution. But I think also asking hospitals to get themselves ready so that drive time isn't going to be the factor may be helpful.
Yeah.
So thank you for that. This is Mark. I think two comments just to integrate this within some overarching HRSA and EMSC initiatives. So one is the pre-hospital pediatric readiness project. So if you're not familiar with that, I'd encourage you to look at that and start thinking about working together with your pre-hospital partners, or if you are a pre-hospital entity, thinking about the concept of pediatric emergency care coordinators and pre-hospital pediatric readiness. There's some resources available on the EIC website, and that project is planning for a national survey in a number of years, but the foundation is being set and the guideline is out there. I think that, you know, the transport times of getting to the patient, as well as getting the patient from the community site to the referral center, really gets at the systems of care. And one of the elements that we didn't talk about today within the Pediatric Readiness Project are interfacility transport agreements, and having those as a EMSC performance measure. So just working together, if you are in a children's hospital with your community site, to smooth the processes and ensure that the teams can call early, call often, and engage you as quickly as possible when and if you're needed. I would highlight, though, Stefanie and Kristin's comment that, you know, if a ED is a community ED and pediatric ready, they have high outcomes. So it's not necessarily saying you need to be a children's hospital, which I think is an important distinction here. Another question was about access to the data set, which I believe that we answered. Pat Frost asked, are you using the CARES cardiac arrest registry for enhanced survival data, or is that being used at all in some of these efforts to link data sets?
Not to my knowledge yet has that been explored, but certainly a interesting and compelling idea to evaluate, particularly in our sample. Again, we only looked at the 5 states with a unique patient identifier and looked at cardiac arrest patients. It was a very small cohort of patients that presented to low-ready hospitals. But if you used a bigger national data set and looked at and linked it to that, that might be a really compelling question to ask and an interesting way to look at the data.
Great. And then Kristin, I think this last question probably is targeted at your expertise. So two questions here I'm going to put into one, just to hear your parting thoughts on. So one is, the first one is, how does health literacy and access to care and Google Maps and searching potentially, integrate into this? Just hearing some thoughts on that from you. I know that's an area of interest to you.
Yeah, I mean, I think it's a question. I don't have an answer of how we can best help families to approach these questions. There are some tools that have been developed. I think that it is complex, and to ask a family to make this decision and weigh all of these factors, if they have multiple emergency rooms that they can choose between, is a lot to ask at a time that a child is emergently ill. But at the same time, we know that most kids show up by private vehicle and not by EMS. And so it is something that most kids arriving in emergency rooms, their families have made that decision.
Thank you. And then the follow-up question to that, which I think is of interest to both of you related to telemedicine, is, this idea of, how small community hospitals or units can leverage telemedicine within the workflow, whether it's either telemedicine with EMS or hospital providers supporting individuals in rural communities and or supporting provider to provider telemedicine. Just interested to hear your thoughts on that.
I think there's a lot of potential power. Some of the pilot studies that we've done have shown some of the usability issues that can get in the way. If it's hard to turn on, hard to find, not readily used, then it doesn't have power. But if it can be made so that there is good workflow and readily available, then I think there is value. And one of the things in some of the interview studies we did, or survey studies, it's worth thinking about the ability of telemedicine to not only provide physician-to-physician consultation, but some of the nurses brought up interest in having additional guidance, and I think the EMS piece that people are bringing up. And so really being flexible and thinking about how we can connect people and get expertise to these to community hospitals is really important.
Thank you so much. I know we're getting just past the hour. I am available to stay on for a few more minutes if Stefanie and Kristin are, but I know a number of people have to leave. So thank you so much for all of you who have attended. We'll share the video. I will sort of ask some of these outstanding questions if we can. One was related to the role of pediatricians. We have a general pediatrician on the line and family practitioners. So is that something that they should be talking to their families about, this concept of like an emergency preparedness plan? We live here, you should go to X hospital instead of Y. That's a very interesting question, Cheryl, and I'd be very interested to hear a primary care pediatrician like Kristin's thoughts on that.
Yeah, I mean, I would be interested in connecting with people on this question to hear how it's approached in different places. I think there's not necessarily a one size fits all, because it depends a little on what's the need and what's the age of the child and those sorts of things. I can tell you my practice, we don't give a blanket statement, but when people are calling in for to our nurse triage line, we will sometimes help give guidance on based on where they are and what the emergency room options are and the need, whether they should go to the children's emergency room versus a closer one if there is one. But that's really case by case. We don't have anything formalized.
So Stefanie, I'll put this last question out to you. which relates to a question from Liz Sanso. I think in other parts of the world potentially, but certainly I think that Liz's experience with IHS or Indian Health Services, this concept of having either a critical care specialist, a pediatric emergency physician or anesthesiologist sort of rotating for periods of time in underserved areas. And just curious if either of you, or certainly Stefanie, from an ICU standpoint, if you have thoughts on that. I think it's a model I have not seen implemented in US hospitals as often until the last 5 years, where I think it is starting to happen quite a bit with this, I call it systemization, where, Yale now staffs many of our regional hospitals. So just a different model.
Yeah, I think a couple of comments on that. So I personally am an academic intensivist, but I also rotate through a community hospital as well as all of my partners. And so, but we rotate through the ICU of that community hospital, which is, sparks my interest in community pediatric readiness, but recognizing that hospital already has an ICU, so already is likely has a ability to care for a deteriorating child more than many. And so I certainly have seen that model employed. But I do think that it's important that we think about pediatric readiness, not just as a provider. Certainly provider competency is one aspect of it, but a provider can be totally competent in their work and skill. But if they don't have the resources they need, then they can't act to benefit a patient. So for example, some of those anecdotes I was talking about, if you don't have a neonatal blood pressure cuff at your facility, you can't monitor blood pressure for a neonate. And that is a huge problem for sepsis and septic shock or, cardiogenic shock. And so I think focusing on the resources and building the resources up to support the staff who are trained to care for these patients is important. And then recognizing that, particularly in low volume centers where there's not a lot of pediatric patients, that skill and competency may wane. So having a mechanism to maintain that is important, whether it be through these facilitating roles coming to your institution and sort of providing a course, or having a pediatric coordinator that really provides quality improvement and maintenance of skills, simulation. And also I think to some of the points earlier on telemedicine, that may be a really great role for telemedicine. So if the provider competency isn't, if the providers feel like their competency has been waning, having access to telemedicine to really support them. And I know that's a very complex issue and most systems can't design it that way, but if it's an issue, it may be a way to help.
Thank you. And I know that everyone's 5 minutes past now. Just looking at the names and the people out there, great to see many of our typical community of practice members, but also great to see an expanding role. So just to loop back to the beginning, we will share information about upcoming meetings. Teresa and I co-chair the AAP Pediatric Readiness Community of Practice. It's open to both AAP members and non-members, and really it takes a village. So all of these ideas that were presented today, I look forward to seeing many people give follow-up presentations on answers to some of these compelling questions or testing these hypotheses about whether or not certain models will work. So we'll share the video. It'll be on the EIC website. And again, Stefanie and Kristin, thanks not only for the presentation today, but for the important work in helping to ensure all children get the highest quality of care wherever it's needed. You really have set the groundwork for us to be able to go out to make that burning platform and those sort of arguments that sometimes have been needed to community EDs of pediatric readiness is necessary wherever you work. So thank you so much for that. Appreciate it.
Thanks so much.
Thank you.
Everyone. Thank you. Bye-bye.